Good afternoon, everyone. I'm Julianne Eckert, and I'm the Director of Quality Clover Health, which is a Medicare Advantage health insurer and a technology company. And what we're doing today is with a panel of industry experts and with member experience increasing to a four-weighted measure and accounting towards more than 55% of the stars pie. We were fortunate enough to grab some of their time to get a take on real innovations in boosting CAHPs and HOS scores and what's actually working. Now, I was scrolling through LinkedIn this week, and the headline to an article that caught my eye, posted by Predict Health on November 29th, the title read, High Medicare Advantage Plan ratings do not guarantee high member retention, and customer service makes the difference. The article goes on to say that customer service is a key measure of retention, even with highly rated plans, and plans should understand how members perceive their handling of customer service issues and optimizing how easy they make it for members. Consumers have said they rate Amazon and Google as best in class in service. In these industries where instantaneous and seamless best in class service is their bar, has the bar moved in member standards for the health plan industry? And are health plans now expected to deliver the same standards as other companies like Amazon and Google? Is 5 stars even enough? And Enan, I'd love to know your perspective on this.
Thank you, Julianne, very much. Hello, everybody. I'm Enam Noor, founder and CEO of Insight in Health. At Insight in Health, through our platform Engage, what we do is we deliver retail-like experience for healthcare cumbersome journey, I like to call it. But what our platform does, we create a data ecosystem. We connect all of this data, whether that's medical records, social determinants of health, and create a real-time insight and understanding. Then our next best action analytics engine drives the engagement at a personalized level. So it's not just a segmented communication or engagement strategy, very similar to Julian, as you mentioned, the other retail industry does, right? And I think we all talk about member experience, patient experience, the experience, right? And it's not a new term, but we think experience is that create a segment, create a conversation, and each department will have their own conversation, right? Creates the data silos. Where you think about, the Amazon, the Googles of the world, they don't look at it that way, right? Each individual journey is important to them, and they are able to do that is by understanding the data. Data is information to them. Data tells a story about a person, and then drive the interventions. And there's a quote by Steve Jobs, who I love, even though I don't use an Apple computer. It's a great quote, and I think we can resonate that retail conversation into the healthcare as well. Is get closer than ever to your customers, so close that you tell them what they need well before they realize it themselves. So if you think about it, like us being the healthcare experts, we have all the data for the consumers, right? Because whether that's claims, their doctor's visits, whether that's health conditions, and we should be able to drive the consumer needs before they know that, hey, if I have diabetes, I not only should be doing the A1C screening, and as I do that, I shouldn't just take my $25 gift card on the way home. I pick up some Dunkin' Donuts and I don't really care, right? It's just like I've got my gift card, but we don't really close the loop, right? Because we need to, and that's where the challenge comes in that you mentioned earlier, that we focus on the quality scores goes up because somebody did the A1C screening, but really you don't close the loop all the way down the line, and they were not satisfied, and at the end they leave you, and retention becomes a challenge, or it impacts the CAHPS score. So you might say the HEDIS numbers are getting better, but why are we losing members? Why is my CAHPS score so low? And retention plays a big impact. You look at any of the retails, right? Amazon Prime, like it's all on our customer loyalty, because if you can keep a customer long term, they're not just staying with you. It's much more cost effective for you to communicate with them because they understand the journey. They become better health literate, and eventually they become your advocate, right? Because they know what's good, what's not good. And we don't see that a lot in healthcare ecosystem today. I know there's a lot of talks around it, and super excited to have some conversation today around it.
That's really interesting, with the quote you said about Steve Jobs and anticipate what, the customer needs. And So with that, and in your experience and what you've seen, is what strategies and personalizations are health plans taking to drive that impact and move the needle on customer satisfaction, not just in ratings, but member experience and satisfaction.
Yeah, it's great question. I think where it all starts is, can we start coordinating our communication with the members, right? Because if you have a quality and stars team, you have a risk adjustment team, you have the providers, you have the customer service, and then acquisition and retention team. They all have programs that are going out, right? And
Mhm.
let's say, take a quick example. In a traditional way, if you're running an incentive programs, incentivizing the consumers for good behavior, whether that's closing care gaps or whatnot,
Mhm.
and a lot of time for workflow, cumbersome process, they don't get the gift card, right? And they're not happy, and they call customer service like, hey, where's my gift card? And all of a sudden, customer service doesn't know the information because the systems don't
Mhm.
talk to each other, right? So we're trying to do something good, and you end up doing an adverse experience, right? So what we are seeing more and more, as we work with our clients is, how do we take few steps at a time? Can we start coordinating some of those outreaches? Can we start having conversation? We hear a lot, there's a care management platform. There's a lot of duplicate efforts, same call over and over and
Mhm.
over. Can there be dedupe? So you're not, making a phone call next day, there's a letter coming in, and then there's a robocall coming in 2 days later, like, because it's just almost like you do the math, it could return. So a lot of this ask is like, can we start coordinating? And not only coordinating, can we start impacting some of the things we talk about? So SDOH, everybody talks about SDOH. So if we understand somebody has a transportation issue, is it good to just tell them go to a doctor's office and close your care gap? They can't even do that. They might be legally blind, that doesn't have a transportation issue, but they might have an SDOH campaign going on, right? They
Mhm.
understand. We're seeing a lot of those leveraging that, as we would like to do those outreach, and if we already identify they have an needs, can we impact that first? So transportation would be, well, can we then enable either that, or would the in-home, test kit could be good enough in that situation, because that's at least close the loops, right? Or if it's around food insecurity, well, if you're already working with, let's say, just an example name, Meals and Wheels, can you trigger that? So they're, SLA will send the meal. So put a gap for 2 weeks and then engage them again, right? So we're here seeing a lot of those workflow optimization, try to get to as close as it can be, like a retail like experience. But look, it's the challenge is real, right? Because there's so many technologies, so many platforms, whether that's your claims platform, whether that's your HEDIS engine, and many of these don't work or talk to each other, right? So even if the health plans
Mhm.
are trying to achieve something, it's that data collaboration creates the challenge, right? So again, we're seeing a lot of those step by step, 1 2 3, can we do that? Can we eliminate excessive contacts and slowly get towards the end goal? So that's where we see a lot of those asks and requests coming from our customers.
And I'll just chime in a little bit because you're exactly right. Every plan's taking a couple of steps, which is exactly what we need, right? I guess the one thing I would add is that I think we've seen a really good realization in 2020 and 2021 during the pandemic that we can't let perfect be the enemy of progress. We're never going to engineer some utopic perfect fix to the U.S. healthcare system under any one health insurance brand name, but rather when we make a little progress, when we're unafraid to ask our member, would you rate me a 10 out of 10? And if they say no, we say, what can I do to change your experience? And then we start to extrapolate that to other members, other issues. We solve what our members tell us when we're brave enough to ask. It starts to really, I think, I'll be brave and say it starts to help reinforce all of what you just said of, are we doing the right things? Are we prioritizing the right first couple of steps? The other thing I'll say that is always amazing to me in this pursuit of sort of, good experiences, when I say don't be scared to ask your member what your experience is and ask their real answer, almost always comes back to very common sense answers of why we're not 10 out of 10 great experiential organizations. When we ask, when we listen, and we start solving, they're not asking for rocket science or asking us to be the next best brain surgeon or astrophysicist. They're asking us to do our core business a little bit better, and they'll usually tell us, which is always super helpful. Always super helpful. It's working well for people to just, chase progress, not perfection, and use common sense by asking your members and actioning what they tell you.
Something that Enam and Melissa both alluded to, I think, as well, is, even within health plans, we're still very fragmented oftentimes, right? When you look at things like what is our care management system versus our member services platform versus how are we communicating with network, what you find is that, Enam gave a great example of sort of a host of services that could be really important to a member, whether it be transportation, social determinants, are they blind, can they access care? If the left hand doesn't know what the right hand is doing, it becomes really difficult to coordinate care in a way that's actually meaningful. And so one of the common themes I've seen in a majority of health plans now that are really taking a stab at member experience is, are we integrating the platforms that we have in some central way where we at least know what each other are doing? So if we're placing calls in member services, does our marketing team have line of sight into that when they send a mailer out? Or when we're calling that member through care management, do we know that member services just talked to them recently or that they got 2 or 3 materials delivered? We're duplicating so much and it's just driving people insane. And I don't know about many of you, but when I get something from my health plan in the mail, even today, it generally ends up in my recycling bin really quickly. So how we're engaging and the way we're communicating amongst those engagements is just so incredibly important. Members feel that when it's disconnected, right? When they get a call from a care manager, 3 postcards in the mail, a call from their provider reminding them to schedule an appointment, a call from a pharmacist reminding them on something for medications, it starts to feel fragmented. And that feeling of fragmentation leads to lower experience. So a big important step, I think, that is actionable that a lot of plans can take now is, are you building the system integrations that you need at the member level to generate actionable insights across your operations from various levels and angles?
Yeah, Anthony, you're so right. And the other thing I will say, y'all, I mean, we're all trying to chase CAHPs and positive experiences, NPS, which is great, right? I mean, it's all the right things when you think about the 50,000 foot level. But sometimes I think that those of us in the trenches forget what our members are. They're not members of anything. They're consumers that have made a conscious purchasing decision to buy a health insurance product as a consumer. And they know what we are. They know we're managing costs and we have to say no. We can't cover everything. We're not endless, we're not endless sources of everything they ever needed and then some. So I feel like I say that because sometimes people forget that we've got, while we're talking about interventions to drive high retention, high experience, 5 stars, think about all the teams in your organization that exist to control costs, to say no, to limit access to drugs and services and docs and services. We kind of have to remember that, like we, like all of us on this panel and all of our friends on the line, we're in that unique spot of having to bridge the gap. Folks that are reaching out to create super positive, I call them CAHPs hugs is my coin phrase, things that are great, warm, fuzzy. While at the same time, you got a bunch of care managers that aren't managing care at all. They're trying to drive high spenders to mid spenders or mid spenders to low spenders. And a lot of formulary and PBM teams saying, you can't have that high cost drug because we can't afford it while we're trying to do the CAHPs hug. So again, Anthony, I think you really put a good punctuation mark on this. We've got to really connect the dots here of what we're really doing as health insurers to the consumer who's bought our health insurance product in a real world, which includes a lot of unfortunate, not great experiences that we have to say no for to control the cost as a health insurer. So I guess that's my long-winded way of saying not everything we do as companies is roses and unicorns. And so CAHPs hugs don't matter if we're really working on high-cost members and rough decisions. We just have to make it as human as we can and treat these people exactly like we would want to be treated if we were on the other side of the consumer purchase transaction. So Cindy, you're on the health plan side. What would you add from a health plan lens?
So something that I took away from my last company is whenever we sent anything out to a member, any promotion that we started, if somebody's going to do an IVR call or drop a little gift box in the mail, I make sure that every member of the company who, talks to a member gets talking points. So, because there's nothing worse than being on a customer relations phone or member services phone and you hear, I'm sorry, I don't know what you're talking about. I heard that so many times before in one of the companies that I worked with. And I promised when I got to, my Albany company that I would never send anything out without them knowing. And I've kept my promise to this day, and we're going on 10 years. And these talking points say, what line of business is it? What was the purpose? What's contained in the letter, in the box that they're getting? Who's going to be calling them? When's it going to be starting? And why we're doing this. And now everybody around the company knows, and nobody's, a question, you put a contact information. So if I've done some member engagements and somebody had a question, they knew that I am the person who sent that out, and they can call me, and they don't have to go chasing around the building trying to find the person who sent something out. So that's important just amongst ourselves to be able to do that.
And I can see too where, that would, it's so important, because I've seen too, it's like, if you have a member calling into your customer experience and they're like, I got a mailer, what is this about? Or I got a call from XYZ, and your customer experience team doesn't know. I mean, first of all, we have a population who is more likely to be prone to scams and are very mistrustful.
Exactly.
But also, it looks like we don't understand what we're doing, and it starts to breed mistrust in us. And I really think that this starts to go into another piece that I wanted to talk about of, we spend a tremendous amount of resources in improving member experience and getting it right. And guys, mock surveys have historically been a really valuable tool in getting a sense of what's working or not. And considering that plans only get a feedback from a part of the survey population who actually respond, and to Melissa's comment earlier that, you've got to get to the member level, and it's really like members are like snowflakes. Everyone's different. How do plans get a read on the entire population so they have confidence that they're fixing the right issues that are representative of, a majority population, and those tactics are helping and not hurting the very issues that they're trying to solve? And Cindy, what are your thoughts on that?
So it's real important to understand why they're calling in. What are they complaining about? What are they unhappy about? You just don't take that message on the phone and you track it in your CRM. What do you do? What are you doing with that information? So on a monthly basis, you should have a member provider satisfaction team that goes through that data, that's looking at trends. It's for all lines of business. It's not just Medicare, because if your member service, if they're complaining about something, chances are it's going to cross all lines of business. So, tracking high volumes, who are those frequent flyers? What are they always calling about? And once you get that information, that's an opportunity to fix it. NCQA is all about process improvements. And so if you can show that you've identified an issue, maybe it's somebody who needs, they're unaware that we have case management that's available for them, or they have a question with our formulary, or maybe it's the website and they can't use, to find a doctor and they're really frustrated with your website. That's telling the company, I need to fix this, and I need to fix it. It comes out in 3 months and 6 months. And that's only if a company does a mock survey. So that's one place where you can do is and that's very simple. It's just running reports. You have that information. You just need to track it. And then you need to respond to it. And also your appeals and complaints department, they're another pulse of what's going on in the company. What are the members, they might not just call you to make that complaint. They might actually put it in writing. And so they're writing to the company. And so track and trend those also, because it's another, they're the voice of our members, whether it's one member, two members, they're telling us what's going on. When you're in a health plan, you all have the same doctors, your competitors, we all have the same doctors, we all have the same hospitals. So they're not really complaining about the provider side. They're really, they're going to complain about what we're doing with them, why we said no. And when we do say no, I used to manage an appeals department. Sometimes you have to say no, but it's how you say no. If you educate them with that no, that goes farther than just saying yes, because now they understand it and they won't take that level and go above you and call Medicare, the 1-800 Medicare and file that complaint with them, because you educated them on the reason why you had to say no. And that goes a long way.
It really does. And I know, and real quickly, it's like, I remember it's like, if, working in if we had to deny it and talking to a member about it, it's like, this is why, but this is what you can do next. These are the
Right.
options, and not just say, sorry, can't help you, but like actually trying to help the member and, navigate through the healthcare. And I'm sorry, I think Anthony, you were going to say something.
I think, Cynthia, you hit on something that's really important, which is the way CAHPS is right now, for the most part, and I think we all realize this, and it's the biggest complaint we hear is it's not actionable, right? Getting information on 800 people when you're a 100,000 person health plan, 800 people is not necessarily helpful in the grand scheme of things. So I think what I've seen a lot of that helps significantly, and there's a lot of discussion about things like CAHPs surveys, and can you embed that in your network and items like that to start getting more proxy data. But one of the systems that I've seen work really well is when you're using encounters-based data to trigger information from your members, right? So somebody gets a service and you want to know the quality of what that was, right? So Enam said something really important early on, which is, are we just asking people how they feel about the care that they're getting, right? In a simple way, like, do we just feel comfortable asking somebody how, Melissa, you mentioned this too, rate us on a scale of 1 to 10, right? Keep it simple. How are we doing? If you were generating that kind of information post encounters, for a majority of your members, this doesn't need to be something that you spend $500,000 on generating surveys throughout the year to track. These can be very simple, actionable items that are down at the member level, right? Mary goes and gets care and she has to go to her PCP followed by 2 specialists. Trigger something at the end of that series of events to ask Mary, what was your experience of having your care coordinated during that process, right? If you're struggling on a care coordination measure, for example, or if they're struggling on things like getting needed care quickly, right? When you see members having multiple encounters in brief periods of time, have system triggers set up that get down to that level and ask that member, was this the right way to deliver care to you? And if it's not, have a follow-up item ready for them, a concierge team that outreads, a member services team, their care manager, right? I think a lot of times we get hung up with trying to find a magic CAHPS bullet that, like, we can jump into the fourth quarter and throw out like 800 brochures and it's going to fix the problem. And it's not. The reality is, like, we need to make CAHPS an actionable data set like we did HEDIS 30 years ago. And that starts with taking those measures and those pieces and embedding it in daily operations and bringing it in across your departments to ask members where they're experiencing negative outcomes, and then putting solutions in place through your existing teams that can call that person and say, we know this wasn't a good experience. Let's talk about how we can do it better next time. Just that conversation goes such a long way in helping fix CAHPS scores.
And it does. And I think if we kind of look at today's conversation, like taking the retail experience into the healthcare experience, like, look, the bar is actually not as high as what Amazon Prime delivers when it comes about healthcare. We've looked at many data from our clients, right? We surveyed a bunch of data and we saw that the customer had a very high satisfaction from the members. And the biggest reason was they pay my bill on time. Like, think about it. Like, they ship my product on time. Like, we don't say that why we like Amazon Prime. Like, no, they show up. Like, so when the bar is lower, we need to be realistic. Let's take that 2-step, 3-step, like Cynthia said. Like, if the phone calls are coming in, let's look at that conversation, because I understand everybody does mock survey, right? Well, let's see who's gonna do this. It's nothing different than an exit poll, right? You take a segment and then try to figure out, and then I predicted wrong, and all of a sudden it doesn't work. It's all reactive, right? Because experience happens in real time. Something didn't happen. I'm not happy. It happened now, and I'm extremely unhappy. And a resolution takes 90 days. I'm way past that. You know what? You're not going to solve my problem. I don't care what calls comes in. So I think creating the prioritization, like what problem should trigger an immediate as real-time possible trigger, right? Technology exists, right? We look at call center data. Well, there's the natural language processing. It exists every industry. We should be able to understand every phone conversation as real time as possible and track bad words, right? Bad words could turn into, we go to forums and places, right? We can't just type what we want to type. Why does that happen, right? So if we create the right prioritization, what could be an extreme, and those could be tackled immediately, and then having a more of, because measuring satisfaction is not easy. It's not an easy job. It is a complicated, because how do you get into somebody's mind that, you know what, are you happy? Are you not happy? Because different people becomes happy at a different level of service, right? So some of the things that we see since this whole shift of the caps on house weighted, going hard, Anthony, you mentioned that, well, look, HEDIS has been going out on the stars measurement, like it's easy to quantify and then, hey, close more care gaps equals to this. How do you get that to a caps on, a HOS rather than just a mock survey? So what we are able to do, we can actually identify before somebody has an adverse experience, what that segment is and what type of adverse, experience they might have. But in this scenario, we don't go and say they're not going to like the nurse. We try to compartmentalize. Well, it might be pre-authorization that took a long time to get a appointment, and call those as gaps, and then just follow the problem. And if you can identify this 5% people you're predicting might have a long wait, well, therefore, can you trigger automated referral management, whatever those could be, right? Because it's a proactive approach. But again, you can't, become Amazon day one. You never need to be, because at the end of the day, it's healthcare. We understand that. And I think creating realistic expectation and following those with the right prioritization, we can improve member satisfaction immensely. And, maybe 5 years from now, we're going to be talking about how to be like Amazon Prime. We don't need to do that today. So again, the expectations are realistic, and we just need to impact those.
Yes, Julianne, I'm going to add one interesting provocative. Well, actually, I'll add two provocative strategies we've seen really take root this year, because this year's been so unique. So, like, you guys are all right. Over the years, we've just sort of defaulted to a standard mock CAHPs proxy survey, right? Send the full list of questions out, gather all the data. And the best thing we got out of it, which was great at the time, was a list of members and the answers each member gave to every question. Now, that's actionable. For a plan like Progress Perfection, a plan that's not at perfection, just doing that is great progress down this path. But I'll tell you, the real world we're seeing now is that nobody wants to do a once a year pulse survey. And like Enam, like you just said, this is a continuum with healthcare. Every day matters real time. So what we're starting to see people do to sustain this is bubble the mock CAHPs into persistent pulses every time you interact with a member, wherever the member interacts. Ask 2, 3, 4 questions that matter to that service. So I'm going to steal Anna Hall, who is on the agenda later this afternoon. Anna, if you're listening, I'm going to steal your thunder, but y'all listen to Anna's talk. She's got like a great example. They're in the pharmacy space filling drugs. They're pulsing out 3, 4 questions. Can you get your drugs? Do you need help? Can you afford them? Like, the button's right on the app. We see that same thing, in online reward platforms. Can't, like one of you guys said a second ago, can't get the ride to the doctor, but you want to go do the service, push the button, we'll get you a ride. That kind of pulsing is really pragmatic and sustainable, and all of us can imagine how we could unleash our own innovation towards that. So that's kind of my first provocative theme, is that mock proxy surveys for CAHPs aren't what they used to be. This is not your grandfather's, Cadillac kind of conversation. But there is always a population that doesn't answer. They hang up the phone before the 3-question survey gets asked. Enam, you've probably got a lot of experience in this space based on what I know about what you guys are doing at Insight 10. This is where inferring experiences based on the claims patterns you're seeing can give you great intel. Your members with reversed and rejected claims, they're not getting the drugs they need. You can guarantee those people, if they get a survey, they're not getting the drugs. Those sorts of things are guaranteed pain points, repeat calls to customer service. The things aren't working well in your supplemental benefit menu, your PAs, approved or not. Like, you can imagine, it doesn't take too much time before we can look in Enam's world at a sort of integrated data warehouse, and we can just write the queries on top of the integrated data set to start spitting out cohorts of members we know are likely struggling in the CAP space as well, if we can't get them to engage with us and give us some feedback. So I guess I'm saying all that to say, I think we're all a lot smarter than we sometimes think we are. We just got to look at our tools and look at our toolboxes and start pragmatically actioning what we've got the resources to invest in.
Yeah, and I think, that kind of segs into what providers, right? So CAHPs and HOS measures are member perception surveys, and especially CAHPs, it's experience, not satisfaction. It's their experience, but they both have significant doctor components in which plans are graded against. For example, CAHPs ask about whether a member saw someone within 15 minutes of their appointment time, and the HOS survey asks if a member, if their doctor spoke to them about sensitive topics like bladder control. Now, knowing that provider practices are really tightly run ships and there are competing insurers with larger or smaller populations within that practice, and everyone's asking these providers to focus on the things that matter to this the insurer. Provider and payer collaboration and engagement are essential to any plan. But Melissa, how do you influence provider behavior for CAHPs and HOS performance?
Okay, so this is a really good question, and I gave this before as we were kind of getting our thoughts together for this panel. I gave a lot of thought to what's different this year in this provider engagement space around CAHPs and HOS engagement. I want to point out that the honest truth is that up until this year, with CAHPs worth a third of our star rating, we have largely glossed over CAHPs and HOS in our provider community. We've seen a lot of plans, even high-performing plans sometimes, that will throw a tip or trick mailer on paper and drop it in the mail or throw it out at the doctor's office. And somehow, Julianne, to your point, somehow hope that these tightly run ships that are usually very sophisticated, profitable business organizations are going to do something different because we dropped a mailer in their lap. So I point out the real world to say, if we want to effectuate change, we have to recognize we're going to have to truly engage with these practices in a meaningful, well-informed fashion, bringing this back to what we did in HEDIS 10 years ago with JOC attention and thorough conversations that aren't just throwing a mailer in the mail. So what does that mean we do? We have to make sure the people we're sending to the doctors understand what they're asking. They're not asking for generic member experiences, like you pointed out, Julianne. They're asking for specific access standards, availability, and discussions. So we've got to arm the people we're sending into the field what the ask is, how to triangulate it into that tightly run ship the doctor's running, and connect it to two things. The doctor's passion of providing clinical care, and in all cases, we can always create the MLR link. So if you're in risk contracts, value-based care contracts, when we educate the dollarized value of bladder control discussions, fall risk discussions, physical activity discussions, access measured by CAHPs to MLR, that's how we start to get buy-in and attention. It's not just trying to swing a bat and hope the doc's going to listen. Two tools that we've seen really make this pragmatic. One, I can't count the few number of plans that write this into contracts. So if you have a contract that basically says, take appointments when my members call, and somehow you think the doc's going to proactively run off and manage the population, you got to write it into the contract. You got to tell your docs what you expect them to do, and then provide them robust panel lists and pay them to resource that tightly run ship. And then we see a lot of plans and a lot of innovation being unleashed in making it easy. So I mentioned earlier in our kickoff call this morning, making sure your technical toolbox is adequate. We have to make sure our technical toolbox does what Anthony mentioned a second ago, where we ask our members the pulse question or the mock question, where we ask them their experience. When they say no, we just action this like HEDIS. We say, Melissa Smith couldn't get her drug, she couldn't afford the copay, or the side effects made her stop taking it. We got to action that more than we do mammograms and colonoscopies. You guys think for a second? So then I want to hear you guys' take too. You guys think about how easy it is, how many years we've thrown gap lists out for mammograms, eye exams, and colonoscopies. We don't think twice. We'll throw the junkiest PDF out on that doctor's desk and we'll unashamedly say, I need you to call those 18 people and get a mammogram, or give you an eye exam camera and do it in your spare time. Now that CAHPs is worth 3 times HEDIS, we don't even spend 3 minutes on CAHPs most of the time, despite all that. So we have to give ourselves permission to proportionately invest the time and the attention into CAHPs gaps the same way we did HEDIS in 2011, 12, 13 if we think we're going to be successful. So that's my provocative thought on engaging providers. But I don't know, Cindy, Julian, you guys are both in the plan space. What are you guys doing? And Enam, Anthony, I'm dying to know what you guys think too.
I think CGCAHPs really have its place because, especially if your CAHPS scores are low on the provider side, my doctor is, doesn't have my information. He doesn't communicate well. Your care coordination score is only a 3. I think that's when you need to really reach out to your providers, let them know that they are agents of the plan and how they, provide that service or no service to our members is really a reflection on you, the health plan. So we really need to work together. You need to have a great, team of provider relations reps that are out there in the doctor's offices, not just throwing a gap list on their desk and saying, please call them for this mammogram, but how can you help me? How can we work together so that the member understands, they have a perception, an expectation of what they're going to get from you. And I've said this for years, the higher the copay, the more they are expected, the higher their expectation. Gone are the days when, and that's how long I've been in the business, over 30 years, that, an office visit was $2 and then it went to $5 and now it's up to $40, or you've got a high deductible plan. So the more money that you're paying out of your pocket, the more you expect from your doctor and from your plan. So we need to work together so that we can identify that and use those CGCAHPs to really identify what practices and where are those practices. Is it a rural area? Is it a city area? Let them compete amongst themselves so the doctors amongst themselves can get better. Create that.
Oh, I'm sorry. Go ahead.
It's all right, Julie.
No, so everything that we've been talking about, kind of leads me up to, the majority of STARS measures are really clearly defined based on specific encounters or services received. We've talked about that, like for HEDIS and access and delivery of care. But since this is not the case with HOS and CAHPS, these measures are based on member-reported results and perceptions of care and service. And we don't have complete control over a member's survey response. And knowing this, as we've been talking about, makes it really difficult for a plan to even, begin to tackle this. What do you think, Anthony, are the challenges that plans are currently facing, and especially with the increased rating? And with the corresponding pandemic and the administrative burden, and what have you seen are the many different interventions that a plan can execute, and what's actually working?
Yeah, so I think on that data part, and I want to connect the interventions lens, we do so much to push information to people as a health plan, right? I mean, whether it's call campaigns to members or sending out brochures. And so I kind of think of the world as almost like it's a push versus a pull of information that we work with our members on, right? The push being we send out a bunch of stuff to them on a constant basis, benefit information when they first come in. So I think that there's a series of interventions that live in that push segment, right? Things like when you bring a new member in, what does your education process look like for helping them understand what their benefits are? And it's different for someone who's brand new to Medicare or brand new to your plan versus somebody who is a renewal member that's been there for 8 to 10 years and you're just kind of re-educating them on benefits. So I think in terms of that push, the push of information is really reserved for things like that, right? A very specific lens that help people access services and care. So when you look at like an intervention angle there, I think that push is really focused on that lens. What we don't talk about very often is more of like the active listening approach. I read a book years ago on active listening and it really changed my perspective on CAHPS actually. When we talk to people, they're engaging with us naturally, our members, right? They're calling us for services, they're calling us with questions, they're calling care managers, they're engaging with us oftentimes as we're engaging with them as well. Those interaction cycles like that pull of information you can get is so important. That's why you're starting to see groups like member experience reps areas enforcing things like active listening with their members, right? Stop just listening to the question about the benefit that they have and try to figure out, is there a reason they're asking this question, right? Is it because they're having problems with something? They had a bad event occur. They had an adverse reaction to something that happened within their system. that to me has formed what I've kind of used as a concept called developing an active listening post, right? Member listening post. This idea about at every touch point with a member, whether it be you pushing information to them or the pull of information that you can get when somebody talks to you, it should be used as a moment to just kind of reflect and collect a data point on experience. But more importantly, what really works is when, and this got brought up multiple times, right? Experience is not something that happens 90 days from when the service occurs. It's something that happens in the moment. So if you can influence that moment and what's happening on that call at that time, that's what really leads to higher CAHPS results. You know, when we look at things like interventions, we can all do fourth quarter pushes on colorectal cancer screening. We've been sending fit kits out for 10 years now because we know that they work. That doesn't necessarily exist with CAHPS in that kind of manner. You can't send out a postcard and a couple of gifts and expect high experience scores. I think of it from the lens of the next time you get to affect experience for a member is the next time they access care. And if their last experience 6 months ago was horrible, you're not changing that perspective until the next time they access care, which could be 9 more months still, or 6 months, or 4. So you're not in a cycle where you can just influence that care gap like that immediately. So when I think about what works in the intervention space, it's moving up the lenses to be as close to that point in time as you can be by that push versus that pull of information. More importantly, it's less about sending out a brochure and things like that, and more about I was talking to Mary in pharmacy, and guess what happened? She mentioned to me that, yeah, I've had a lot of problems accessing your network over in this county, right? We just moved here. Oh, let me connect you to somebody over in member services, because if you haven't updated any PCP assignments, we may be able to find one that's accepting. Or, you know, we have a really amazing telemedicine program. Have you thought about just, we can help get you set up with that real quick if that's something of interest. It'll speed up time for you. It'll help you access a specialist quicker. There's so many things like that that plans are offering right now that aren't just being leveraged by members. So speeding up that point of care piece like that, that immediate connection, that in my mind from an intervention lens is what really works. And then it connects back to that really point in time data that you get.
I think like Jillian, oops, sorry, go ahead, Melissa.
Go ahead.
The one thing I would add to that, don't forget your folks who just give up, because everything you just described, Anthony, is awesome for the person who can actually get to the point of service. But there are so many, I mean, think about the volume of folks we're working with. There are so many people who simply are not utopically motivated and persistent. They just give up. So we're all sitting in our homes, right? Like if you look at our homes, imagine the people that are low MLR, you can see it again, back to data. You can see their struggles in the absence of encounters and the absence of drugs. Those are the folks that may have just given up that we need to find, because when they get a survey, they'll fill it out and their negative response won't be a negative experience. It'll just be the absence of experiences.
Well, and I think that's where, you know, Anthony was saying active listening is key, because when we do have those touch points, I think when you add skills like motivational interviewing and empathy and conflict resolution, service recovery, I mean, those are things that, you know, I've had in my quality training programs for years, and it like really drives the communication skills of every single member facing employee, you know. And so I think that that was really key that you said, because I think it's really where we get out of like trying to that push pull of extracting that information, because if we don't know what's broken, we can't fix it. And you know, I'm sorry.
No, I was going to say, I know we have a lot of time, quickly touch bases. I think, you know, the biggest, you know, key here is like the, you know, Anthony mentioned push pull. Anytime there's an interactions, it's generating data, right? From technology, I will look at it as like data is going to drive information that could then create decisions and movement, right? That's what all the big tech does. You know, it's a data that drives it all. Like if we now look at lens through the, you know, the healthcare, Jillian, you mentioned like CAHPS is an experience, not necessarily satisfaction.
Mm-hmm.
It's a workflow. How do you impact that? It's going to happen. There's so many elements, right? Well, okay, well, we can create a data transparency across the board with the payers, providers, nothing new. Can we have accessibility, what the consumer needs? Even to a point, can we actually start predicting better? Think about it like we look at Weather Channel, it's going to rain. Therefore, take an umbrella. So I'm not going to get wet. I might not like your rainy season, but I took an action. I didn't get wet. If my question was, did you know it was going to rain and did you get an umbrella? If the answers are yes, well, you know, you're getting plus scores, right? So if we look at how other industry leverage data to impact, whether that's experience, whether that's satisfaction, we can do that in healthcare as well. Because there is no abundance of data. We have to look at data as an asset and drive decisions off of data. If we can do that, we can get closer and closer step by step.
I mean, if
Thanks,
you
guys.
really think about this for a second, right? Like, imagine a world in which all of you on the call and everyone, imagine if you could had an experience score on every member in your health plan right now, right? Something simple, 1 to 10. What would you do to all the members that were below a 4, right? What would you outreach to them? Would you figure out why? Would you talk? My guess is yes, right? Because that's what we do with HEDIS. We have a gap in care that starts on January 1st and extends to December. And so we do things because we see that gap and it's visible. If you had a way of looking at experience for every member on your plan, even 50% of them, because you had good feedback loops and mechanisms to capture, my guess is many of you have probably a ton of ideas about things you would do in those various ranges for people that were experiencing care differently, right? I think that's a lot of what we're kind of all universally talking about here is there's no reason that can't exist or that system can't be created within your organization. It's a lift and it takes resources and time and energy to collect that information. But if we really want to get serious about changing CAHPs, we need to get down to that level. Member generated experience scores is just vital to the success of really tracking where people are.
Yeah. Well, with that, Anthony, Cynthia, Enam, and Melissa, I really thank you all for joining me today and talking about this. It's been really insightful, and I've learned a couple things too, but appreciate your time. So.
Thank
Me
you.
too. Well, have a great afternoon.
You
Bye,
too.
everyone.